Patients' willingness to defer resection of diminutive polyps, results of a multicenter survey. Introduction. The effectiveness of colonoscopy is based on the detection and removal of precancerous polyps. Current colonoscopy practice is to remove all polypoid lesions irrespective of their size or appearance. Most polyps are diminutive, and approximately half of these are hyperplastic polyps and not cancer precursors. Although the other half are adenomatous polyps and, by definition, dysplastic, they very rarely harbor or progress to cancer. Studies evaluating polyp progression have shown a very slow growth of small polyps without increased risk of cancers within surveillance intervals. One recent longitudinal study examined the growth rate of diminutive polyps that were not resected and found a mean size progression of 0.6 millimeters after a mean of 7.8 years of follow-up. Another study using computed tomography, CT colonography, determined that ignoring diminutive polyps was safe and cost-effective. By applying a Markov model to a hypothetical cohort, this study concluded that removal of diminutive lesions would carry an unjustified burden compared with the minimal gain in clinical efficacy. These findings are reflected in the CT colonography guidelines, which support a non-resection approach for diminutive polyps unless growth is detected at the subsequent surveillance examination. The concept of deferring resection of diminutive polyps is currently only applied in the context of screening with CT colonography or colon capsule endoscopy. Although the technology is different from colonoscopy, the same goal applies to all three tests: to detect and remove neoplastic lesions to reduce incident cancers and, by doing so, reduce colorectal cancer (CRC) mortality. However, it is plausible that the colonoscopy practice of removing all diminutive polyps also represents unnecessary overtreatment, because these lesions may never progress to a cancer stage within the individual's lifetime. Deferring polyp resection would lead to cost savings, both from reduced pathology and equipment costs. It can be assumed that cost savings would be greater than with resect and discard, which has been estimated to provide annual net savings of over $730 million. These cost savings are primarily based on the decreased need for pathology evaluation, as a U.S. study found that the cost for a colonoscopy without polypectomy is $1,000, while the cost of colonoscopy with polypectomy and pathology is $1,500. Because cancer in diminutive polyps is exceedingly rare and the use of image-enhancing techniques can usually identify the presence of advanced histology in diminutive polyps, a discussion about adopting the practice of diminutive polypectomy deferral seems warranted. To determine whether deferring resection of diminutive polyps during colonoscopy is safe and does not increase cancer risk requires a large prospective trial. Given current endoscopy practice, it is unclear how patients would respond to the idea of deferring resection of diminutive polyps and whether they would be willing to participate in such a study. The authors conducted a survey to evaluate patients' willingness to defer resection of diminutive polyps and the factors associated with this decision. Background and study aims. Current colonoscopy practice requires removal of diminutive polyps. This is associated with costs, but the benefits to colorectal cancer (CRC) prevention remain unclear. The study aim was to understand patients' willingness to defer resection of diminutive polyps and to examine the factors that influence patients' decisions. Patients and methods. Adults presenting for a colonoscopy were surveyed at 3 hospitals in the USA and Canada. Survey domains included patient characteristics, risk perception, knowledge about CRC risk, willingness to defer polyp resection, and associated concerns. The primary endpoint was the proportion of patients who would be willing to participate in a clinical trial that deferred resection of diminutive polyps. Secondary endpoints included factors associated with willingness to defer diminutive polyp resection. Results. 557 eligible individuals completed the survey, mean age 63, 61% men, with 50% of respondents being willing to participate in a randomized trial in which resection of diminutive polyps would be deferred until the next surveillance colonoscopy. 95% confidence interval, CI, 46% to 55%. Outside of a clinical trial, 57% of participants would be agreeable to deferring resection of diminutive polyps. 95% CI, 51% to 63%. Willingness to defer diminutive polyp resection was associated with higher education, p equals 0.001, greater knowledge about cancer risk, p equals 0.002, and a lower perception of cancer risk, all p less than 0.001. Age, sex, income, a history of polyps, and a first-degree family member with CRC were not associated with willingness to defer diminutive polyp resection. Conclusions. More than half of individuals undergoing a routine colonoscopy would be agreeable to deferring resection of diminutive polyps and participating in a trial to evaluate this approach.